most of the times you'd have more efficient absorption on an empty stomach. But yet, and still, oftentimes we do advise patients to take certain medications with food. And that's because of the potential for GI irritation. So a lot of drugs will irritate the GI tract, and it's recommended that they take them with food. But just outright, as far as the absorption, in most instances, the absorption would really be better without food, okay? Generally speaking, the rate of absorption, but not the extent of absorption, is reduced in the presence of food. Let me see if I can explain that a little bit better. And these are just guidelines, okay, that food will generally increase the, I don't want to say increase, I want to say decrease the rate of absorption, drug absorption. Now, drug absorption. And since you promised me that you're here in the past, I'm going to let you fill in the rest. Food will generally decrease the rate of drug absorption, but not affect the extent. You're going to fill in the rest now. Those that are not here might miss the rest. Okay. Food will, generally speaking, decrease how fast the drug gets into the bloodstream. That's rate, how fast. We talk a lot this semester about rates, but not the extent. The extent is how much. So generally speaking, why do you think the food will decrease the rate? We talked about this the other day. What about food would more than likely decrease the rate, how fast it gets into the bloodstream? Because food does what to gastric emptying? Decrease. Well, you told me this the other day now. Okay, even though we weren't specifically talking about the effect of food. Okay, so primarily because of that effect on gastric emptying, the drugs want to get to the small intestine where most absorption occurs. But if food slows down gastric emptying, you just told me the other day that that's going to tend to decrease the rate. But the extent of absorption, okay, is usually not going to be affected by food. How much drug gets into the bloodstream is usually not affected. It's just how fast it gets into the bloodstream. Okay. I have some examples here in my notes of some drugs where the absorption rate the absorption rate is reduced. Some examples of where the absorption rate is reduced in the presence of food. I have digoxin as an example, acetaminophen, acetaminophen. I have a couple others. And I'm sure there are a lot more. These are just examples. Nitrofurantoin, not nitrofurantoin, don't write that. Pentobarbital sodium and cephalexin. Pentobarbital sodium, that's the sodium salt of pentobarbital, but you already know that. Pentobarbital, sodium pentobarbital. Is pentobarbital an acid or a base? Cephalexin. Now let me go get Dr. Milton on here. Is pentobarbital an acid or a base? Acid. How many say acid? How many say basic? Pentobarbital. Pentobarbital, I only saw like 5 or 6 hands. Pentobarbital an acid or a base? Acid. Okay, remember the other day, I don't know if it was here in the lab, but that concept of knowledge on demand. Okay, pentobarbital is an acid, but if you didn't know for certain, you could have guessed because I'm talking about the sodium salts. So think of things like sodium acetate, the salt of acetic acid. So sometimes the salt form will give it away. So pentobarbital itself is a weak acid. Very good. Okay, so those are some examples. These are examples of where food will actually decrease the absorption rate of the drug. Okay. And we already talked about the fact that milk milk, because of the calcium, forms this insoluble complex with drugs like tetracycline. So milk will reduce the absorption of tetracycline, and that's due to that calcium complex formation, which is insoluble. So the tetracycline forms a complex with the calcium in milk, and that complex, okay, is not soluble, so therefore the absorption is decreased for the tetracycline. And then I have here some examples of drugs where the absorption is increased after a meal. So here are some examples of drugs where these are examples where the absorption is decreased, especially the absorption rate. Okay. Remember we said that the extent of absorption is not going to be, is usually, these are just guidelines, not laws. The extent of absorption usually is not going to be affected by food, but the rate of absorption is what's affected. So these drugs will show you decreased rate of absorption in the presence of food in the stomach, the ones that I listed here. Okay, some drugs that show increased absorption after a meal are drugs like griseofulvin, increased absorption, hydrochlorothiazide, and nitrofurantoin. So 3 examples of drugs that will show increased absorption after a meal are griseofulvin, hydrochlorothiazide, and nitrofurantoin. Okay. Food also causes, food also will cause, I say food leads to an increase in hepatic blood flow. Let me see if I can find a marker. Food will lead to an increase in hepatic blood flow. This is the one. And you remember some drugs do undergo a so-called first pass effect. Now we only deal with or concerned about a first pass effect if during that first pass through the portal circulation that a significant extent of the drug undergoes metabolism. So because food does increase hepatic blood flow, that increase in hepatic blood flow could lead to a decrease in the first pass effect. Okay, so I'll say possible decrease in first pass effect. Let me see if I can reconcile that for you, because over the years I come up with all these kind of explanations to hopefully simplify things. So if the drug is in the bloodstream, and I'm saying possible, okay, not necessarily it's going to decrease the first pass effect, but imagine that drug that's in the bloodstream has been absorbed across the phospholipid bilayer and all that kind of stuff. So now it's in the portal circulation. And food speeds up that circulation, that hepatic circulation through the portal vein. If that drug is dissolved in that blood, and those enzymes want to attach to that drug to catalyze metabolism, doesn't it make sense that if I speed up the rate at which that blood is going through the liver, that I might get more drug past the gate, the enzyme system? Because it's moving through the liver faster. So the enzymes won't have as much time to, okay. So that's the Felder little explanation. You ain't gonna get that in the book, but that's the way I reconcile in my own head how speeding up the blood flow as a result of food, okay, could possibly cause a decrease in the first pass effect. Okay. You ain't gonna blow that come next Monday, right? When I have this as a choice and I have all these other distractions, you ain't gonna blow this, right? During the review, I ain't gonna have 30 or 40% of the students that miss this concept, right? Okay, I'm gonna see. So I have a couple of examples here of drugs where the first pass effect is decreased in the presence of food as a result of this, okay? So 2 examples I have are propranolol. So in the presence of food, propranolol will show a decrease in first pass effect. And hydralazine, that's Hydralazine. What's that drug used for? That blood pressure? Okay. So, so examples here are hydralazine and propranolol. Are two examples of where if a person has food in their stomach or eats while taking these medications, that the first pass effect could actually go down. Let me see if I have anything here. That's on the food effects. That's all I have on the food effects. So the last thing I want to talk a little bit about is malabsorption. Malabsorption. So just the fact that we call it malabsorption indicates that, hey, something's going wrong with the absorption process. So malabsorption is defined, the definition of it is any disorder with impaired absorption of fat, carbohydrate, protein, vitamins, electrolytes, minerals, and water. I will repeat that. So malabsorption is defined as any disorder where we have an impaired absorption of fat, carbohydrate, protein, vitamins, electrolytes, minerals, and water. So it doesn't pertain to just drugs. You know, some of these other compounds can be affected as well. Drug-induced, some drugs will induce malabsorption, and some drugs that have been shown to cause malabsorption are neomycin. Drug-induced malabsorption is caused by drugs such as neomycin, phenytoin, and methotrexate. So I've given you the definition of malabsorption. Some drugs will cause malabsorption, and those are just three examples: phenytoin, methotrexate. What was that third one I said? Neomycin, yeah. Neomycin. Sorry, somebody have a question?
Can you repeat the definition?
Yes, I can. I can do that. I will do that. Malabsorption is defined as any disorder with an impaired absorption of fat, carbohydrate, protein, vitamins, electrolytes, minerals, and water. So if the absorption of any combination of those occurs, then that is indicative of malabsorption. Okay? So malabsorption has to do not just with the malabsorption of drugs, but vitamins and minerals and water and other things also. And then I gave you three examples of drugs that can cause, quote unquote, drug-induced malabsorption. Okay. And then I have here in my notes also that 5-fluorouracil. This is kind of like a variation on the theme here. 5-fluorouracil. What's 5-fluorouracil? What class of drugs is that? Used in cancer treatment? That's what I thought too. Okay. It damages the GI epithelium. So that's the lining of the GI tract. So 5-fluorouracil, when taken orally, can damage the GI epithelium, and that can lead to the increased absorption, check this out, of large polar molecules such as tobramycin and polyvinyl pyrrolidone. I'm going to spell that polyvinyl pyrrolidone out. Polyvinyl pyrrolidone. I think that's right. I won't tell that. Sometimes abbreviated as PVP. So 5-fluorouracil can damage the GI epithelium. Okay. So that membrane is compromised now, that bipolar membrane or whatever. So that will allow large polar molecules such as PVP, polyvinyl pyrrolidone. Okay. What other molecule did I say? I gave you one before that. Y'all taking notes, right? Or recording, right? What else did I say? Tobramycin. I mentioned that. I said, yeah, so also tobramycin. I'm trying to see, I see some folks, I guess they're recording or whatever. So here are two examples of where the administration of 5-fluorouracil can damage the GI epithelium and then lead to increased absorption. So that's kind of like the opposite of malabsorption of large polar molecules. So these are two examples of large polar molecules. I mean, generally, do this for me. I just thought about this when I said large polar molecules. Do a little bit of research for me and see if these two molecules, just on their own, not in the presence of 5-fluorouracil, just on their own, if they're absorbed. If they're absorbed very well. Because usually polar molecules usually are not that absorbed. You remember we said that the lipophilicity is, polar molecules tend to be more water soluble. But we said that in order to be absorbed in the GI tract, it had to be water soluble and lipid soluble. Because it got to dissolve in the GI fluids to be dissolved. I mean, to be absorbed in the first place. So in order to be absorbed from the GI tract, a compound has to have both lipophilicity and water solubility. But we said of those two requirements, the lipid solubility was more important because that phospholipid bilayer is more lipid soluble than it is water soluble. So I'm curious now, this question never occurred to me before. See if these compounds, just do some research. See if therapeutically, if they're administered orally. You might already know that. Tobramycin, or is it only after the administration of 5-fluorouracil that these things can even be absorbed in the first place? Because I don't know. A lot of compounds are not given orally, just like a lot of compounds are not given IV. Okay. So my question is, are these two compounds, can they normally be administered orally? There might be parenteral preparations too for these two, but I just want to know, are there oral formulations of these two compounds? Okay. That's my question to you. Okay, so that's all I have on physiological effects concerning GI absorption. Again, we didn't do the subject justice. We had 2 or 3 lectures on it, but I think that we have introduction enough that we can lead into our next major pharmacokinetic model. I didn't check. I think that in your lecture schedule, I think the next topic, even before this model, is GI absorption formulation factors, but I could be wrong. But if it is, we're going to skip that for now because we really do need to move ahead into this absorption model. And then if I'm skipping formulation factors, I'm saying if because I didn't get a chance to. I didn't take the time to look at the lecture schedule before I came in. Formulation factors might come after the introduction of this model, but at this time, since we got a test week after next or whatever the case may be, and we have laboratory next week, we need to move into this model for absorption so that we can prepare for that upcoming exam. So today we're just going to do an introduction and then we'll continue this next week. Again, come here again. Are you here? See me after class. Okay, I have something for you.
Yes, sir.
So the next model that we're going to deal with is a one compartment open model, with first order absorption. I won't write this title on the board every time, but I'm gonna draw the model so you know that we're talking about this title. I'm talking about next week, okay? With first order absorption and, because right now this tires me out, first order elimination. Okay, so this is the model we're gonna be dealing with. This is the name of the model. if you say absorption model, I know what you're talking about, okay? But here, this is descriptive, very descriptive of the model, because it lets the reader know that we talk about a model that has first order absorption, described by first order absorption rate constant. It's a one compartment model, because we got a two compartment model also that we can have absorption in. We're only gonna cover a one compartment model for absorption and call it a day, okay? And then we have elimination from this model, it's also first order. KEL, we got KM, a metabolic rate constant, and we got KU, the urinary excretion. So this model has a lot in common with just a regular one compartment IV bolus dose. Before I go any further, I want you to recognize that as drug, the body here is represented by this one compartment. So as the drug enters the body, okay, since it's only one compartment, we're assuming that the drug is immediately distributed throughout the body once the drug enters the body, okay? Unlike with the two compartment model, we got a slow phase of distribution, or an alpha phase, a fast phase of distribution, then a slow phase of elimination. So in this model, generally it's going to be used to describe the absorption of drugs after an oral dose. So that's why I wanted to take some time to talk about some of the physical chemical factors pertaining to GI absorption. We've talked about some physiological factors pertaining to GI absorption. So kind of keep those things in mind as we talk about the actual pharmacokinetics now related to absorption. So although this model is usually used to describe drug absorption from the GI tract, and I've said this before, it can also be used to describe drug absorption from an intramuscular dose or subcutaneous dose of drug, or intradermal dose of the drug, where an intradermal dose, the drug goes down to the dermal layers of the skin, and there are capillaries there, and the drug can get absorbed to the bloodstream. When a drug is administered via suppository, either vaginally or rectum or wherever else suppositories can be delivered, this model could apply. It could apply to intranasal administration. When a drug is absorbed from nasal passages, okay, into the bloodstream or something like that, okay. So don't get stuck on just oral absorption, but we usually talk about it in terms of oral absorption because, again, the oral route of administration is the most common route of drug administration, period. Oral administration trumps all of those other routes. It trumps IV. So generally, we associate this model with oral administration, but I don't want you to think that it's just oral administration that this model pertains to. We okay with that? Let's talk about, from laboratory, we already talked about the fact that F is a fraction of the dose that's absorbed. So in laboratory, we did a little mathematical exercise on Tuesday and Wednesday, and we let F be equal to 0.8, and the D is the dose. So if 80% of the dose, in the laboratory, we just assume 500. If 80% of the dose is absorbed, then this F will be equal to 0.8. If 50% of the dose is absorbed, F will be equal to 0.5, okay? Later on, maybe our next major topic, but that will be after your next exam. At some point in time, we're going to talk about bioavailability. And this F, another name for it is just absolute bioavailability, as far as we're concerned. Okay. But right now, we can just refer to it as the fraction of the dose absorbed. Okay. Does everybody have a clear understanding of what F is? Because the whole dose may not be absorbed. We might have some of the doses that undergoes first passive phase, gut wall metabolism, acid catalyzed degradation. There are a lot of reasons why, if I give a certain dose, that all of it might not end up going into the bloodstream. Okay, so F is that fraction of the dose that enters the bloodstream. Are we okay with that concept? Okay, very good. And then this Ka is a first order rate constant for absorption. First order, so that means it's going to have units of reciprocal time. It's a first order absorption rate constant. If it's a first order absorption rate constant, that means that the half-life for absorption is 0.693 over Ka. We're going to learn how to calculate Ka, the first order rate constant for absorption. So in this model, unlike the IV dose, remember the IV dose, we had that little squiggly arrow here. We said, well, that indicated an IV push, where pretty much the drug is all going into the vascular system all at once. We know we're not just going to push the drug in 1 second. But, you know, over a period of, you know, maybe a couple of minutes or so or less, depending on the volume and whether that drug is an irritant or whatever, it's gonna be introduced fairly rapidly into the bloodstream for the IV bolus dose. Rapid administration, right? Immediate administration. Here, the drug is being absorbed from usually the small intestines in the stomach, in the GI tract, okay? But it could also be other sites of administration, as I just said. So it's not going in all at once. It's being absorbed in a first order fashion from the site of absorption. You okay with that concept? Okay, if you take an aspirin tablet, don't just, if it's a 5-gram tablet, the 5 grams of aspirin don't all just appear in the bloodstream all at once, okay? It's absorbed over a period of time, okay? So that's what's happening here. But then once drug does enter the body, okay, then that drug immediately distributes throughout the volume of distribution, just like it would with an IV bolus dose. Once it hits the bloodstream, okay, this is the C is the plasma concentration, just like it was before the one compartment model, and A is the amount of drug, okay? Okay, don't get blindsided again. If I ask you to calculate the amount of drug here is the plasma concentration, which we played around with the plasma concentration equation in laboratory, okay, on Tuesday and Thursday. So it's the plasma concentration times the volume of distribution. All three of these amount, which is usually in milligrams or grams or micrograms or nanograms of the quantity. Plasma concentration is usually in concentration units, milligrams per liter or micrograms per mil or whatever. Volume is usually in liters. Okay. But, I mean, if the volume of distribution is 30 liters, that's the same as 30,000 milliliters, but usually we're going to express it as liters, okay? And then we have these first order rate constants for the exit of the drug. So it's an open model, and I think I had a multiple choice question on one exam. In fact, it's an open model because we have these routes of elimination. The drug can get out. It's open for the drug to leave, okay? These mean the same thing as they meant before. KEL is the first order rate constant for drug elimination. Km is our first order rate constant for metabolism, usually by way of the liver, but there are other organs that sometimes can metabolize drug. And Ku is the first order rate constant for urinary excretion. AU, if we have time, we'll talk about, not for this upcoming exam, okay? We're gonna be focused for this third exam. But if we have time this semester, it's in the syllabus. It's just a matter if we have time. We talk about urinary excretion in this model. If we don't, it's no big deal because most drugs that are monitored, you know, for you know, your drugs like phenytoin and maybe theophylline and vancomycin and gentamicin, a lot of drugs are monitored because they have a very, very narrow therapeutic index. And most monitoring is based on drugs in the plasma or the serum and not out here. Okay. But it's still good to know what's happening over in the urine. So we prioritize plasma concentration because that's what most therapeutic effects and pharmacological effects are monitored based on what's going on here, okay? If we have time, we'll do urinary excretion also, okay? In this model, just so you can understand, KEL is still equal to KU plus KM. If it's only these two routes of elimination, okay, then that overall first order rate constant for elimination is still the sum of KU and KM. So don't look at this and see three separate routes of elimination. There are two. Okay. Just like before, if none of the drug undergoes metabolism, then KEL is equal to KU. If none of the drug is metabolized. If none of the drug undergoes urinary excretion, then urinary excretion would be equal, KU would be equal to 0. So in that case, our KEL value would be the same as KM. Okay. In this model as it's depicted right now. Okay. So we can express the rate of change of drug in this model as the change in the amount of drug in the body, this A right here, is equal to Ka times X, and I'll explain this X in a moment, minus KEL times A. Let's put that in parentheses so we're gonna know what we're talking about. Where X in this equation is equal to F times D times E to the power of negative Ka times T. So basically what I'm trying to show here is this is an F, the fraction of the dose that's absorbed. So instead of putting all of that in the equation, we just put X there. But think about this for a moment. We swallowed this aspirin tablet. It's 5 grams of acetylsalicylic acid. It's over here at the absorption site. This is just saying, this F times D times E to the power of negative Ka times T, it's just saying that the amount of drug at the absorption site is decreasing because it's going from here to over here. So it's decreasing in a first order fashion. So this X in the equation is equal to the fraction of the dose that's going to be absorbed times whatever dose we administered times E to the power of negative Ka times T. So the drug is decreasing, the drug is decreasing from the site of absorption. I'm gonna say at the site of absorption. That's F times D is our starting amount we can get in the bloodstream. But it's decreasing in a first order fashion described by E to the power of negative Ka times T. It's going down. Okay. So we start out with F times D. So at T equals 0, at time equals 0, right after the dose, E to the power of negative Ka times T is equal to 1. So that's this F times D right here. But it ain't gonna stay at F times D, it's going down because of the absorption process. So that's the input. So that's causing this absorption process. Is it causing the amount here to go up or down in the body? The absorption process, is that contributing to A or taking away from A? Contributing. I want you to remember that because I want to draw the plasma concentration time curve and then it'll make sense, okay? So if it's increasing A, then that means also increasing the concentration, right? Because the volume is going to be a constant, okay, very good. And then minus KEL times T, that's just like in the one compartment model of the bolus dose. This process is taking drug away, so that's why I have a minus sign here, okay, in front of that. So this is a plus sign in front of Ka times. Like you don't have to write the plus sign, all right? Minus KEL times T. So this is the equation that describes how fast the amount of drug in the body is changing. Okay? If we look at a plasma concentration time curve, concentration versus time, and you've seen this, I think, before in pharmacology or pre-pharmacology, or whatever, the plasma concentration time curve kind of looks like you've seen that type of curve before somewhere, I'm sure. So you see, I made it curving up and curving down, but if we take the logarithm, if we plot common logs on the common logs or natural log versus time, we can straighten out those curves where it would look more like this. And have a, So we're going to be dealing, this is just concentration versus time on just say rectilinear paper. So we're not going to be looking at the actual concentration versus time on rectilinear paper. We're going to be looking at either the natural log or the common log of those concentrations on semi-log paper. So on semi-log paper, just like with the one compartment model, we can plot concentration versus time and the curve will look more like this. So see how we got that curvature in this space there? Well, on semi-log paper, or we plot the logarithm of concentration, it straightens that out, okay? So we can draw straight lines. So what we find is that I know, I'm not referring to my notes, I know I'm probably missing something, but I'll catch up on it on next week. I want to give you an assignment to work on, so that's why I'm kind of. So the equation that governs the plasma concentration is the same equation I gave you in lab. The equation that governs this plasma concentration time says that concentration is equal to F times D times Ka. That's the Ka is the numerator, sports fan. Ka minus Ka minus K. Yeah. Times E to the negative KLT minus E to the power of Ka. Okay. So this is the equation we played around with in lab today. This equation describes this plasma concentration time curve. This equation describes this time curve. So you told me that here, Ka times X is causing A to go up. If it's causing A to go up, it's going to cause the C to increase, okay? So this phase where the concentration is going up is because of this input of Ka times X, okay? And initially, we got more drug coming in this direction than we have drug going out. The KEL times A is not that high early on because we don't have much A to drive, this process. So early on, the rate KEL times A, the elimination rate, let's do this also. Let's call this the absorption rate, drug absorption rate. It ain't broken out like this in your textbook, okay? But I think this might help. And we'll call this the elimination rate, the drug elimination rate. Elimination rate. And so I'm breaking this rate equation. This is the overall rate equation. I'm breaking it into two components: the absorption rate, Ka times X, and the elimination rate. So early on, the absorption rate is greater than the elimination rate. So let's think of your partially stopped up sink. If the water is coming in from the faucet, going down the drain, but it's coming in faster into the sink, it's partially stopped up. If it's coming in faster than it's going down the drain, is the water level going to stay the same, or build up, or decrease? It's going to build up. That's exactly what you see here. Is that if you consider this absorption rate as water coming in, okay, because it's coming in faster than it's going out, then we get increases in concentration. We get increasing amount and the concentration of the drug. But as the amount of drug in the body builds up, because KEL and Ka are set, they don't care. They just depending on the drug or whatever. But the amount of drug here is changing. So as the amount of drug changes, the elimination rate changes. So as the amount of drug builds up, the elimination rate gets faster. Now remember, we're losing drug from the absorption side. So eventually, Ka times X is trumped by KEL times A. So once KEL times A, the elimination rate gets faster than the absorption rate, then concentration and amount start going down. Once this elimination rate gets greater than the absorption rate, then this curve starts going down. That's why it's going down, because the drug is being eliminated faster than it's being absorbed. So remember in lab the other day, but I said I'm going to repeat everything and I'm going to expand upon it. When this drug is going up, when those concentrations are going up, that's referred to as the absorption phase. So here, when it's going up, that's the absorption phase. Absorption phase. When concentrations are going up, that's the absorption phase. And when they're coming down over on this side, this can be referred to as the elimination phase. Elimination phase. Or it can also be referred to as the post-absorption phase. Post-absorption. Post-absorption phase. We together still?
Yes, sir.
Okay, I'm gonna try to wrap this up. I know it's Friday, right? It's Friday, and it's raining. I just got my hair done, so. Absorption phase, elimination phase. We still together? Okay. We'll talk about, you know what Cmax and Tmax are, but I'm gonna skip that for right now. We'll come back to it later. Let me just say that when concentration is highest, that's Cmax. We'll talk about that a little bit more next week. And this time down here, like I told you in lab, what's that time down here on the x-axis? Tmax, exactly right. So we'll talk more about the calculation of Cmax and Tmax and stuff like that. But I can just say right now that at Cmax, the elimination rate and absorption rate are just equal. So prior to Cmax, prior to Tmax, remember I said that the absorption rate is higher than the elimination rate. So on the left side of Tmax, the absorption rate is higher than the elimination rate. But on the right side of Tmax, the elimination rate, is higher than the absorption rate. I just talked about why that is with the sink. But right there at T max, these two rates are exactly equal. And it's just that one moment in time, as Whitney would say. Whitney Houston, that is. Okay. Y'all too young, y'all too young. She had to hear, you know. Okay, so at T max, the absorption rate and the elimination rate are equal. So that means that the overall rate of change is equal to 0 at T max. This delta L over delta T is equal to 0 at T max. Let me see if I can do this right quick. If I can. In this model, Ka is normally greater than Kel. Normally, not always. We'll come back and talk about the other situation or whatever. But when Ka is greater than Kel, just bear with me. I'm not gonna keep it much longer. When Ka is greater than Kel, then as time increases, when Ka is greater than Kel, which is a normal situation, which one of these exponential terms, in other words, we're going to do some simplification. And I told you in lab on Tuesday and Wednesday that we could take this model and we could simplify it so it has just one exponential component instead of two exponents. But I didn't want to do that on Tuesday and Wednesday, but I want to get you comfortable with using the whole equation. But when Ka is greater than Kel, which one of these terms, e to the power negative Ka times t or e to the power negative Kel times t? I'll call this one term A, and call this one term B, just for this discussion. Officially, these are not called term A and A. This is just for class participation right now. Which one is decreasing faster, A or B? A, by show of hand. When Ka is greater than Kel, which one, and the time, now you know from our laboratory exercises passed this week, the times are going to be the same in both of these. So at a given time, which one of these would be the smaller term, A or B, at a given time? Would be the smaller term. At a given time, A would be smaller? Come on. You're breaking my heart because if Ka is greater than Kel, that's a negative exponent, okay? B is going to be smaller. Because we're assuming the normal situation where Ka is greater than Kel. So if you choose a time, put that time here and here and calculate that value, you're going to find that B is smaller than A. So that leads me to my next question then. Which one is decreasing faster? Which one is approaching 0? Because neither one of them is going to actually go to 0 no matter how big the time is. We talked about that before because of the nature of that exponent. Which one is approaching 0 faster? B, very good. Exactly right. B is approaching 0 faster, okay? Neither one of them is going to ever reach 0. So that by the time we get in the post-absorption phase, when we reach the post-absorption phase over here, this term, B, we can ignore. Now this is only going to be true in the post-absorption phase. If we're in the absorption phase, we got to use the whole equation. If we're in the absorption, we can't do, we got to use this whole equation if the concentration or the time is over here in the absorption phase. But if we're over here in the post-absorption phase, then guess what? C can be determined by this equation, but if you use this right here, you're going to get pretty much the same answer. Because that e to the power negative Ka times t ain't contributing nothing. You just told me that now, so don't be looking like, well, what are you talking about? So this can be used to calculate concentration or the time to reach a certain concentration during post-absorption. I'm going to say only here, during post-absorption. Only. Okay? You can't use this short form of the equation if you're in the absorption phase. It ain't going to get, like I like to say, it won't get you in the hall of fame, it'll get you in the hall of shame. If you use this equation during the absorption phase, okay? So I'm going to do one more thing and I'm going to stop. I wanted to show you how to get estimates for this KL, but if you want to read it here in the book, you can. I'm going to forego the assignment because I don't think I'm going to have time to do it justice, and then we'll pick up on it on Tuesday morning, okay? And then I'll give you an assignment, and I might have to lecture a little bit in the laboratory, okay? So if we take the logarithm of both sides of this equation right here, we'll have that the log of C is equal to the logarithm of F times V times Ka divided by V times Ka minus Kel, I'm going to say in brackets, minus Kel times T. And let me tell you what I want you to see here, so you won't be intimidated. I want you to see the log of C is equal to the log of C0 minus KEL times T, because the math that you're going to be doing, even though we got all these different characters in here, it's the same old script, same old storyline. So if you can handle the log of C is equal to the log of C0 minus KEL times T for the one compartment IV bolus dose, you can do this too. Don't forget what we've already learned early on. So I hope you see the relationship. I mean, So basically, this equation, okay, this logarithmic, and you can write this with common logs also, okay. Common log of C is equal to common log of all this stuff minus KEL divided by 2.3. So it's up to you which way you want to go. But if we're looking at this plasma concentration time curve, remember we said that equation, that this equation applies to post-absorption phase. This logarithmic equation came directly from here, right? So if I'm looking at just the post-absorption phase, if I got that data, I can draw a best fit line, okay, and run that line all the way back to the y-axis. All the way back to the y-axis. And the slope of that line, according to this equation that describes the line, would have a value of what? The slope of this post-absorption phase line would be equal to what? Anybody? The slope of that post-absorption phase line would be equal to what? Come on, sports fans. I told you the first day of class, you got to hold on to this stuff. The equation that describes the thing says that the slope of that line would be the natural log of K, I mean not the natural log, it would be equal to negative KEL. I've already said that I'm putting C, this is presumably a similar log paper, okay? So if I put C on the y-axis and I put T on the x-axis, ain't nothing left but the slope and the intercept. The slope is going to be equal to negative KEL. Because this equation is the form of y is equal to mx plus b. If you ask me if I'm disappointed, which you didn't, I am disappointed because y'all sitting out there like, what the heck is he talking about? You know, I don't know about you, but once it got to be 950, I clocked out. I'm gonna let you. Okay, so the slope is equal to negative KL. You calculate it just like you calculated the slope. Exactly the same way. You take 2 points on this line. They don't have to be in the data set. And 2 times, and calculate the slope of that line. Just like you did with the one compartment. Exactly the way you did it. So I ain't gonna spend a whole bunch of time going on it because you're gonna do it exactly. It's only one line, you can calculate the slope of that line. And this intercept right here will be equal to F times D times Ka divided by V times Ka. Don't call that C0 because that's not C0. It's this part of the equation right here. So if you do this on semi-log paper, this would be the y-intercept. If you do it on rectilinear paper, you would be applying the log of C, just like we learned how to do this, even though we spend most of our time on semi-log paper. We can do this on rectilinear paper, we have to apply the natural log or the common log of C, okay? But on semi-log paper, then we don't have to take the anti-log of this to get this value here. We can just read it right from the graph. So whatever that value is on your semi-log paper would be equal to F times D times Ka divided by V times Ka minus KL. Just like when you plotted this on semi-log paper, that intercept wasn't a logarithm of C0, it was just C0 on semi-log paper. But if you do it on rectilinear paper, to get C0, you had to take the anti-log of that intercept. Because on rectilinear paper, you plotted logarithms. So all of those y coordinates were logarithms on rectilinear paper. But we're using mostly semi-log paper. So on semi-log paper, you just read C0 directly from your y-intercept. On semi-log paper, you're going to read all that fancy looking stuff in those brackets directly from the y-intercept. I'm going to stop right there. And we'll take this up on Tuesday morning, okay? Hold on to this, okay? And then on Tuesday, I'll make you an assignment or whatever for us to work on and to further consider that stuff. We're gonna next week learn, so I'll review this on Tuesday. But from this, now we can do so-called method of residuals, and we can get estimates for Ka also. So we'll get estimates for Ka by using the method of residuals, and then I'll show you how to calculate the Barnum distribution and that kind of stuff, and we'll be ready to rock and roll. Y'all have a good weekend. Hey, hi, how you doing? I remember.
Oh, can you sit beside real quick?
Oh, sorry. Can you take a picture?